Can you hear me? All right. Thank you for coming to our fourth Mixed Methods Seminar Series seminar this year. And today we're joined by Dan Matlock, who leads the Patient-Centered Decision-Making Core in Accords, and he's here to talk about a project that he's been working on that involves convergent mixed methods. So he'll recap a little bit about what that means. It will be fairly focused on the quantitative, but then Megan Morris, who's leading the qualitative aspects of this project, can talk about what they've learned from the qualitative and put it in context and talk about how they've converged these results a little bit at this point. The project is still in progress. After today, we have two more seminars. The next ones are focused on results and analysis and publication. So stay tuned for that. Please come back and check out how you wrap up all this work and disseminate your findings. So thank you for coming, and I'll turn it over to Dan.
Thanks. All right, thank you all for coming. So no conflicts of interest, and there are some of our funding acknowledgements for our group. So I stole a couple of slides from the very first Mixed Methods talk just to reorient everybody to the different types of mixed methods designs. And that first talk talked about four designs: exploratory, sequential, explanatory, sequential, convergent, which is what we'll talk about here today, and then embedded. And just very briefly, I liked these figures, so I just kept them in here. The exploratory is you do the qualitative. You see? Okay, good. You have the qualitative first, and then you connect from results from the qualitative results to do your quantitative data collection, and then you interpret the connected results. Explanatory sequential is sort of the opposite, where you do your quantitative first, but then you want to kind of find out what they mean. And this is more what we did here, where we collected, the quantitative and qualitative simultaneously, and then merged the two sets of results in our interpretation, which is a process that we're still sort of doing. We'd probably be a little further along, but we've been working on a couple grants, and so we put this on hold for a month or so until those are in. But I'll at least talk about what we collected and why, and then we can give you sort of preliminary thoughts on what we're finding. So the benefits with the concurrent approach is it's easier with timing since both are done at the same time. You don't have the years of work of doing the qualitative before you do the quantitative. You can see what's happening at the same time, and it minimizes the recall bias. Some of the drawbacks is sometimes your two methods might give you contradictory data, which I don't think we saw, which is good. And then one could potentially influence the results of the other, intra-method mixing, which we might be doing. I might be doing some of that in my head, actually. And then the last design was this embedded design, where you're really doing a quantitative data and the qualitative is sort of embedded within. And I'm actually not quite sure how this is different from the convergence when I was looking at the slides last night.
Like a priority difference.
Yeah, maybe it's a capital quant, lowercase qual, or something like that. Yeah, no, that might be what it is. But I was looking at that and I was, I wonder what's different about that. Anyway, this is the fourth design. So I want to talk about our project that we did with there's a PCORI project implementing these decision aids we developed for left ventricular assist devices at 6 sites around the country. It was a combined effectiveness implementation hybrid. So we collected effectiveness data, which was mostly quantitative, and then we studied the implementation of the tools at the 6 sites, which was a little bit of quantitative and mostly qualitative. And I'll show you some of those results. But I feel like anytime I talk on this, I need to give a little bit of background on what a LVAD, or a left ventricular assist device, is. And then I'll discuss our trial and our design, and then I'll show you some of the results that we've just gotten in the last month or two. So this is actually an advertisement that showed up in one of our mailboxes for this left ventricular assist device. The end of the line with medical therapy doesn't mean an end of life discussion with your patients. HeartMate 2, the left ventricular assist device. So this is the current version of the partial artificial heart. I'll show you a little bit what it is, but I really hate this ad. This is, I think, when you're done at the end of the line with medical therapy, it's a perfect time for an end-of-life discussion. And part of that discussion might mean you proceed with a ventricular assist device. But it doesn't mean you run away from the discussion and just throw pumps in people. So this is what an LVAD is. This is actually a picture from our decision aid. And you see there's this pump here. and you punch a hole in the left ventricle of the heart, and you suck blood out of there, and and then you pump that blood through the aorta. And part of heart failure, the definition of heart failure is a heart that's too weak to pump blood to meet the needs of the body. So if you have a weak heart, this is a way to augment the blood flow of that left ventricle. It has this wire here that connects this sterile body to this external unsterile world, which it will be important when we talk about some of the complications. And then that hooks to this battery pack, and you have to wear this 7 or 8 pound battery pack, or you have to be plugged into the wall. And you do this for the rest of your life. So this is really the current permutation of the artificial heart. The first artificial heart was Barney Clark in 1982, and I think he lived for like 100 days in the ICU, and they took out his whole heart and put in a new heart. And that was the first permutation. And then now we have the LVAD, which is really that assisted pump for the left ventricle. And this is what Vice President Cheney had before he had his heart transplant. He had one of these for a couple years. These are amazingly beneficial in terms of survival benefits. At 12 months, without the LVAD, 2 out of 10 people are alive. 80% die. With the LVAD, 7 out of 10 are alive. So that's a number needed to treat of less than 2. There's very few things we do in medicine that are like that. And people who survive the surgery feel a lot better. But there's a ton of complications that go with this. So 55% or over 5 out of 10 get rehospitalized every year for major complications. 3 out of 10 have a major bleed in the first month, and 2 out of 10 have a major bleed in the last 11 months in that first year. And it's this simultaneous problem. You have to take a blood thinner when you have the pump, and then the pump chews up all your blood clotting factors. So you have like this double whammy reason to have these bleeding complications. 1 out of 10 people get a stroke per year. 2 out of 10 have a serious device-related infection. I mentioned there's that drive line that connects to the world that's not sterile, to the sterile cavity, and those get infected. And there's a lot of work trying to keep those clean. Then the devices can malfunction due to clotting. This is one thing that we may have to change on our decision aid, because with the newer generation devices, they've solved this problem a little bit. The newer devices don't clot as much, but they haven't solved these big ones over here. And then some people have ongoing heart failure. It's a left ventricle assist device. If the right side of your heart's still having trouble, and that's still causing your symptoms, then it doesn't treat that side. So
Is there for some reason not an RVAD?
there is an RVAD, and there's BiVADs, and the data's not as good. It's the right ventricle is a thinner wall, so it's harder to do procedures on. It's a lower pressure system because the lung system is much lower pressure. So they just don't do as well. There is one, and they don't do as many of them, and they don't do as well. I don't know the data as well, but we don't do very many of them here at all. I don't know very many centers that do, but there's everything. So heart failure is increasing. I know this is hard to see as the years go up. Heart failure continues to increase. This is men and women. And the available of organ donor hearts is not increasing. So it initially went up. The yellow is Europe, the green is the United States, but this has stayed pretty static. And we do about 2,500 heart transplants a year in the United States. But the LVAD is increasing. And last year, this only goes up to 2013, we're now doing more LVADs than we're doing heart transplants. So people say this is a niche therapy. This is not a niche therapy. It's becoming fairly mainstream for advanced heart failure. And they're even funding some trials to do this in people with less severe, not in-stage heart failure, to see how well those patients do. So this is typical technology in medicine, right? We adopt it, it starts getting used, and then it explodes. One of the things that caused this to explode here in 2009 is originally these were approved for bridge to transplant. Get a pump to get you well enough until a heart becomes available. And so they would just use it in a small number of people that they were really just trying to keep alive. The younger patient with no other comorbidities that's really a good candidate for a transplant. We just haven't seen a heart yet. And then in 2009, the FDA approved it for destination therapy, which are people who will never be eligible for a transplant. Main reasons you're not eligible for a transplant is you're too old or you're too sick. So now it's now indicated for people who are older and sicker. Oldest person in the country that we know of, at least in the Intermax data to get an LVAD, is 88 years old. Some data, they cost around $300,000 for the first year on average, cost to the healthcare system. And according to some of my heart failure colleagues, these are the highest profit margin procedures for the hospital. So hospitals are eagerly trying to grow these programs all around the country. So that's a little bit of background on the LVAD of what it is. Any questions on that? It's an interesting thing, and it highlights a lot of interesting things in medicine. All right. So now a little bit of our trial. So we in the Colorado Program for Patient-Centered Decisions, we developed a lot of decision aids. That's one of the things we've done a lot with. We have some work in defibrillators. We've done a lot of work in other cardiovascular procedures. But so one of them we developed was this LVAD decision aid. And I guess when we developed this decision aid, we actually did sort of an exploratory approach where we did the qualitative data first to find out what people needed to understand about the decision. And that data informed our design of our decision aid that we then used in this trial. And some of the things we learned from that original needs assessment is our decision aid had to address emotion. Everybody we interviewed, these are patients dying in the ICU. One patient we interviewed 4 days before he died, he declined an LVAD and said, I'm going to go to hospice. I've lived a great life. My life's had meaning. I don't need to do something like this. But everybody had a lot of emotion around it. And this is one of the quotes I remember. It's get the LVAD or push up daisies. So some people didn't even feel like there was an option. Everybody wanted to hear patient narratives. And this is a controversial thing in the decision aid world because once you start putting patients in videos, you're going to have biases and influences in ways you may not even understand. But it was actually a pretty easy decision for us to do that. And it's an implementation decision because patients go on YouTube and get narratives from Thortec of the guy who's doing pull-ups with his LVAD hanging off of him, which is not the norm. That's about 22 standard deviations above the average. And so if we didn't include narratives and try to balance those narratives, then we didn't have any control of any sort of narrative, and they were going to get influenced in some other way. So it was almost an implementation decision to include narratives. We're very careful to use process narratives, not outcome narratives. So people say, here's how I made the decision, here's how I made the decision, and not this was the best thing I ever did, or this was the worst thing I ever did.
You put yours out on YouTube?
Ours are free on our website. We use Vimeo. We have an account with Vimeo because they could hold it for us. But yeah, we put them free on our website. And then we have a long video. And in our pilot trial, some of the patients said things like, I wish it was longer. We were really worried that people wouldn't watch that video. But once they started seeing other patients, they said, I wish it was longer. I wish I could hear from more patients. So we designed this decision aid. And then we wrote a grant to study this decision aid. There's a Cochrane review of decision aid trials that 115 decision aid trials, and they almost always improve patients' knowledge and other decision outcomes in these efficacy trials. When you have a research staff sit with a patient and they watch this thing, they're going to know more and understand more. That's not really an interesting question. But then all these decision aids are sitting on shelves somewhere and nobody's picking them up. So we kind of took that thinking and said, let's do a combined effectiveness implementation hybrid. This is how we got to this trial. Let's study both effectiveness and implementation at the same time. And this is how we got into the quant and the qual and the mixed methods approach. This is just a little more on our design. I'll skip some of this so we can get to more discussion. So the objective of the trial was to understand the effectiveness and implementation of a shared decision support intervention for advanced heart failure patients considering DT-LVAD. So the key things we considered as we were designing this trial is we wanted to evaluate implementation in several real-world settings. It's a small population, relatively. There's 160 sites, and each site does like 50 a year. And we could only afford about 5 or 6 sites. So we needed 6 sites to answer our quantitative power questions. And we needed some sort of randomization to assess for effectiveness. And so that's what sort of led us into the design that I'll talk about coming up. So the designs we considered a classic patient-level randomization. But the intervention is both patient and program-based. At the sites, these programs are like teams of people talking to patients and educating them. And if you just did a patient-level randomization, there'd be all kinds of diffusion effects into this team of people. So we didn't really think that was a good idea. A cluster randomization is a really nice design, but with only being able to afford 6 sites, that would be 3 in the intervention, 3 in the control. That didn't really feel like a good idea, especially since the programs are pretty different. It'd be hard to really balance that. So we did a step wedge cluster randomization design. And step wedge is a neat design. It's basically at each site, it's a pre-post design, but you randomize when they get the intervention. And so one of the weaknesses of pre-post designs is underlying secular trends, but if you randomize the rollout of the intervention, maybe you can at least control for some of that. In reality, looking at our quantitative data, I'm not sure that's 100% true. We're still heavily influenced by some of the things that happened later on that might be secular trends and not just our intervention effects. But we'll talk about that a little bit in a bit. But yeah, so we had 6 sites, and this is how we rolled them out. So step wedge is ideal when you have diffusion of intervention to control participants is likely. It's nice when implementation is a focus because you can study the implementation at each of those sites and you actually have time to study it as they're being rolled out. It's nice when there's a therapy that all the sites want to use. If this was a really dangerous intervention, you really needed a randomization trial, as a step wedge is probably not a good idea, but the sites were very interested in using the intervention. So to evaluate this, we used the RE-AIM framework. This is the framework that Russ Glasgow developed, and it has 5 domains: the reach, effectiveness, adoption, implementation, and maintenance. And I'll talk about each of these on I think it's the next slide. Oh no, I took that out. So reach is the proportion of eligible patients that receive the intervention. It's conceptually the easiest one. It's mathematically the most difficult because it's really hard to figure out who that population of eligible people is. Even in something like an LVAD where they're sitting in an ICU, there's still patients that come in, they're like, yeah, maybe I want it, maybe I don't. And when they become the eligible population is actually really complicated. The effectiveness, we looked at knowledge and value concordance. Adoption, did the sites take it up and did the people at the sites take it up? Then implementation is how did they use it? Was it consistently used? We measured this both quantitatively and qualitatively. And then the maintenance, did they continue to use it after the trial? And we measured this quantitatively and qualitatively as well.
Is use the LVAD itself or your materials?
Oh, the materials. Yeah. No, the materials. That's a good question. That comes up. I should clarify that. That comes up every time I present this. Yeah, no, the LVAD is just what's right for them. It's did we get them to use the decision aids? We started collecting data in May of 2015. We finished patient enrollment in July of 2017, and we actually had the 6-month data finished in December. So we just finished collecting all of our 6-month data. And then through this intervention, we did interviews. We did an interview at every site before the implementation. This little stair step is the step wedge design. We did an interview at each site about 6 months after they implemented to see how things were going. And then we did an interview after the data collection or after the last patient was enrolled when they no longer had any incentive to use the decision aids to see if they continue to use those decision aids. And we interviewed 3 or 4 or 5 people at each site. The interview 1 was done all over the phone. Interview 2, Jocelyn Thompson and I traveled to each site and interviewed a host of people at the sites. The interview 3 was just 1 or 2 people over the phone to find out if they're still using it for maintenance. So we ended up interviewing like 70 different interviews. Yeah, Julie.
Staff or patients?
Not patients, staff. So one of them, almost always the heart failure director or the LVAD director, whoever was the most in charge person of this particular program. Always an LVAD coordinator, so each site usually has 1 to 4 nurse practitioners that manage their LVAD patients. We'd always interview that person. Always interviewed the social worker. And then after those 3, it was whoever else we could, maybe another doc, maybe some of the nurses, whoever else the site PI thought might be key informants for us. And really after about 3 or 4 interviews at each site, we had a pretty good idea of what was going well and what wasn't in the implementation. Usually after the first interview with the site PI, we had a pretty good idea. And then all the other interviews were pretty much confirmatory. But we got more information on maybe why from some of those. Questions? One of the aha moments for me in implementation science is you have your effectiveness intervention, the decision aid, And then you have your implementation strategy, which is separate. And these things overlap and mix, but it's helpful for me to see them separate. So our implementation strategy in this was to identify key people at each of the sites, and we found sites where we already had buy-in. And then we did an implementation visit. Larry Allen and Colleen went to each site, and they gave a 1-hour presentation, a 1-hour communication training, and then a discussion with the team on how they're going to use it. So it was a high touch in terms that we traveled out there, but then it was a pretty low touch implementation visit. There wasn't hours and hours of work beyond this. It was just sort of a half-day thing. We tried to build it into conferences that they were already doing at each site. And then post-implementation, we had monthly phone calls with the site PIs, but one of the things that's emerged from our qualitative stuff is that we didn't really support the communication as well as we could have within the sites. Even the sites that were doing well and using it, if a new person was hired, they had no idea that this decision was being used. And that was something that we thought about as we go into the next scope of work. We didn't want to do a whole lot of implementation stuff, because once you do more implementation stuff, you have less generalizable implementation. It gets more expensive, and it's less likely to be a strategy that'll work after your trial. So our outcomes. So the primary outcome for the trial from the quantitative perspective was decision quality. And decision quality is defined as a patient, an informed patient making a decision consistent with their values. So to measure that, you measure how informed they were by measuring knowledge. And then you measure some sort of measure of value concordance. And if you have somebody with low knowledge and low value concordance, we'd say that's a low quality decision. If you improve knowledge, you get an informed patient. If you improve knowledge and value concordance, like the choice that they choose was concordant with their values, then you have a higher quality decision. This is at least the theory behind this. I think you can quibble with a lot of this, and are these the right things to measure in every context? I don't know. I wonder if at the end of life, if making sure people are really informed is as important as value concordance. But it's hard to measure these kinds of things. So this is the measure we use.
Do you try to include any kind of objective measure of value choice, or is it entirely subjective as to what they want?
Oh, I'll show you. I'll show you how we measured the value concordance, because that's a hard thing to do. It is sort of it is what they want. So the way we measured value concordance is we had a scale, and we said place an X on this scale. And on one end is do everything I can to live longer, even if that means having major surgery and being dependent on a machine. Or live with whatever time I have left without going through major surgery or being dependent on a machine. And then if somebody puts an X down here and they end up getting an LVAD, then that would be concordant. And if somebody put an X down here and they end up not getting an LVAD, that would be concordant. And then likewise, this would be discordant. That's how we measured that. So we used a linear mixed model, adjusted for time trends and significant differences at baseline. And then to measure value choice concordance, we used a Kendall's tau correlation coefficient. Excuse me. We enrolled 248 patients from 385 eligible, so a pretty high proportion eligible that enrolled. We'd planned for 168 with our power calculation, and this was an interesting thing. This is part of the secular trend. All the programs in the country were doing more at the end of the trial than they were doing at the beginning, and so we over-enrolled. And usually you would stop a trial, but with this stepwise design, you can't stop the trial early. You have to kind of keep going through and collect all the data. And so that we were paying each site a per patient incentive. So we had to readjust our budget to find money to pay them the per patient incentive, which is a good problem to have, but it's kind of unique and something we didn't expect. A challenge with stepwise designs, if you ever think about that, something you got to think through. But otherwise, the populations were pretty similar. At the intervention delivery, at the training at the sites, all the sites participated in the training, and up to 31 to 72 staff members per site came to the training. That's the big grand rounds. And then fewer came to the communication training, and then the smaller team actually was there when they discussed what's going to be their strategy for implementation. 88% of people received the pamphlet decision aid, 92% received the video decision aid in the implementation arm. So this is some of the quantitative information we collected around the implementation. We had the study coordinator fill out a checklist for each patient on how it was used. The study coordinator wasn't allowed to give the decision aid to patients. That had to be the clinic staff. That's the implementation side design. But then the study coordinator would be like a fly on the wall, watching how it was done, or at least talking to them afterwards to get information on how it was done, so we could study the implementation quantitatively. And then the education materials were felt to be a little biased in favor of the LVAD. In the control, 54% of patients said it was biased towards the LVAD. In the intervention, that went down to 43%. That wasn't significant. But even our tool that we really tried to balance, patients still felt like it was in favor of the LVAD. Something that came out, not in this study, but in another study where we saw that with defibrillators. We asked patients how they interpreted that question, and some said, yeah, I think the data says you should get a defibrillator, but I don't think it's like you're trying to push me to get a defibrillator. So I'm not sure if we can really understand what people were answering in that question. Is the tool biased, or do they think the data supports an LVAD because they're focused on living longer? So here's our results. We did improve decision quality. We had a modest increase in knowledge. In the control, knowledge went from about 60% to 65%. In the intervention, it went from about 59% to 70%. So that was a difference of 5.5%. And that was significant. And then the value choice concordance on the Kindle's tau correlation went from 0.17 to 0.48. So pretty good improvement on the value concordance. So for the patients, we did improve decision quality. Secondary outcome, and this was pretty interesting and is politically interesting too. We weren't trying to change the LVAD implantation rate. That's not the goal. But in the intervention arm, there was a 26% absolute decrease in people who actually went on to get an LVAD. And this is where I think some of this is the effect of our video. Some of this might be changes, some underlying secular trends where sites were becoming more cautious with LVADs in general as they saw more and more complications. So while the step wedge design is kind of nice and does let you randomize the rollout, I still think there was some underlying secular trend around sort of their caution with patients. And I think even sites became more comfortable with patients not getting an LVAD as the trial went on. Whether that's from our intervention or the whole effect, I think it's really hard to tease that out still, even in this quasi-experimental design. There's clearly something here, and it's important. Yes? Oh, it's the people who didn't get the decision aid. So before we implemented, we started collecting data from all of them on day one on their decision, and then they got just whatever the sites were doing. Which at the sites, there's a team of 4 to 6 people that meet with the patients, and most sites were handing the industry materials to patients. But we just let them do whatever.
So with the step wedge, does that mean that the same facility might be both control and intervention then later in the study?
Yeah, every site is both a control and an intervention.
So the reason you think the secular trend wouldn't have affected the control is because sort of by definition the intervention comes later?
Yeah, at every site starts in the control. Then at 4 months, one site's an intervention. At 8 months, 2 sites are intervention. So if there's something just globally happening a little different at the end, you get rid of some of those effects with the randomized rollout, but not all of them.
Yeah, well, if your intervention later, do you not leave any pure controls? Are they all intervention?
All intervention by the end.
Yeah, that does seem like it.
Yeah, it gets messy. Yeah. So we went to the sites and we said, we'd love for you to plug and play, unplug the ThorTech tool, which is a video where the first doctor says, oh, there wasn't much thinking about it, get it or die. And then use our video instead. And then we studied that. And at some sites, they didn't use the industry material at all. And some sites still continued to use both. And the industry materials are nice. They're nicely produced. They're glossy. The little device rep comes and they're free and they give them to them. And it's hard to compete with some of that. And especially some of the post-care, the aftercare instructions, like how you do dressing changes. We didn't put that in our video. Ours was really around the decision. So they're still using some of those industry materials as well. But we at that implementation visit, we said we tried to get sites to do a plug and play. We weren't completely successful on that. But that's part of the implementation design is you want to let them continue to adapt the intervention to how they want and what's right for them. Good questions. More questions?
Can I just add
Yeah.
So for the qualitative, I would say that part of it was the implementation thing. They were so used to using this materials, and that was sort of their process. So it was getting them to not only add something else, but take it away was also, I think, a potential barrier to the implementation, or to stop one and start the other.
Yeah.
It's just easier to start one versus two actions.
Yep. Yeah, totally. Just want to make sure we have time for discussion. So secondary outcomes, we didn't see any differences in some of these things we expect that you often see in decision aid trials, like decision conflict, decision regret, control preferences, stress, depression, quality of life. No changes between the two groups on those. Caregivers, we tried to enroll a caregiver for every patient. We did pretty good. We got 182, so about 60 patients we didn't enroll a caregiver. And caregivers, we improved their value concordance as well with what they want for the patient. We insignificantly changed their knowledge, only a 4.8% difference in a smaller sample size, so P was 0.08. But, trends in the right direction. The caregivers were interesting. The caregivers' decision conflict scores decreased, but they decreased a lot less after seeing our decision aids compared to the control. So in the baseline control, we collected two baseline, one before the decision aid, one after the decision aid. And conflict was 19, high as 100, low as 0. And that went to 2.6 in the control. And in ours, that went from 21 to 9.3. So,
Sorry, just a quick question. Did you separate out different kinds of decision conflict? I thought they shouldn't, but they should, or they should. You see what I mean? Or is that...
Well, decision conflicts is 15-item validated scale, and there's 5 subdomains like values, clarity. I forget them all, but we didn't actually separate them out to look at this, like which type of conflict. It's a good question. We can do that. We're just starting to analyze data, so we haven't quite unpacked that yet. But yeah, if there's one type of conflict that didn't come out, but it's interesting that the caregivers' conflict didn't go down as much when they watched the LVAD video. And that's kind of an interesting thing, that the something about watching the industry materials is reassuring to the caregivers, because they say things like, oh yeah, this is going to be the best thing you ever do. Yeah.
It almost sounds like
Yeah, we're not sure this is a bad thing, but it's an interesting thing. And, some people might think this is a bad thing. And, is it good to berate people and give them the right information in order to create ambivalence? We think it is, but I think that gets into sort of a debate about what's right. It's kind of interesting. Let me get to the implementation evaluation so we can get to some of the qual stuff on how we actually did the convergent mixed methods, or how we're doing, I should say. So the interviews with the LVAD program staff in 6 sites, the 3 sets of interviews I mentioned, 49 total participants, and I mentioned who some of these people were. And our aims were to understand the evaluation education process pre-intervention, evaluate implementation of the intervention, and assess maintenance of the intervention. At maintenance, all 6 sites ended up using the decision aids, or all 6 sites used them throughout the intervention period. 5 out of the 6 sites continued to use them after the enrollment period ended. And 4 out of 6 plan to continue to use them after the study ends. 1 site's working on it. They have some sort of institutional policies about any sort of educational material that's given has to be branded by their institution and approved by multiple committees. It was fine as part of a research study, but now that it's out of a research study, it has a whole host of approvals it has to go through. So it's a big barrier to implementation at an institutional level for that. And then 1 site had a lot of skepticism about it, had skepticism during the trial. This one of the things that came out in the qualitative interview, the site, they were the least enrolled site. The first patient who watched the video at their site decided not to get an LVAD. The head heart failure there almost shut the whole trial down. And it was really interesting, the interviews at that site. It was pretty clear that the way that implementation and rollout occurred at that site was different than some of the other sites. We had a more junior person as our site PI there, who didn't really have the agency to challenge some of the leadership there. And as we interviewed some of the other people, they kind of said, yeah, you need to go talk to the leaders. He can tell us to do what he wants, but you got to go talk to the leaders. Because that's one of the ways that we're starting to understand some of our site differences around that. I think that's it. I think we'll stop. These are all slides from something else. So maybe we'll stop there. Oh, just real quick on this. This is the second to last slide. So we just submitted a grant, actually just pushed the button today to do a next phase of this work. We feel like we have a successful implementation. We have an efficacious intervention. PCORI's funding a limited competition thing for things they've previously funded, effective shared decision-making interventions for dissemination. So we're going to try to disseminate this tool to all 162 programs around the country, using the diffusion of innovations theory to kind of determine which programs are going to be early adopters and which ones are going to be laggards, and then give them different implementation strategies based on where they land on our assessment of the diffusion of innovations. We'll see if that gets funded, but that's where we're hoping to go, is to start pushing this out even further. Maybe I could bug you to help me talk about some of the qualitative findings a little bit as well, if you don't mind, Megan.
Is there anything you want me to specifically?
Yeah, well, maybe some of the implementation evaluation, because we have these effectiveness results, but then we have 6 sites, and how well did we do at implementing it, and why? Some of the things about like how people were very interested and they felt it was helpful, even in,
Yeah. So in thinking about the hybrid design for implementation, there was the effectiveness and implementation. I would say it was really where the implementation is where the qualitative. We weren't doing any qualitative for effectiveness, just the implementation. And so thinking about kind of convergent is, so how this kind of team works is we had our quantitative team and we had our qualitative team, and we kind of, collected data and admittedly did a lot of, I was on the qualitative team. So, we did our coding and we had our kind of preliminary themes, and then we all kind of came together and say, okay, what's going on here and how is one explaining the other? So, for example, there was great uptake of the decision aid. And so, one of the questions is why? Why did these sites actually have such a great uptake of it, such a great adoption? And that's where the qualitative came in to help explain. In their interviews, we realized that they felt like this sense of responsibility that the team did to educate the patient properly. And they felt like they just didn't have the tools to do that. And that's where this decision aid came in, and they felt like it really helped them do their job. So it wasn't, a lot of times, Dan talked about at the very beginning is, decision aids don't get adopted into clinical practice. And what seemed to be different about why this one got adopted so well was that it was not an add-on. It was something that really helped them do their job. So they wanted this. This was kind of a need. And so, again, that helped explain what was going on.
Yeah, because in a lot of decision aid trials, they'll use them for like 10% of the eligible people. And here we had them using them in like 90% of the eligible people. And so it's really a different context where people really wanted to make sure their patients were informed. And it was through those interviews that we understood that better. And there's this pressure, there's at least in some of maybe with side conversations, there's pressure at these sites to keep their they have to get 10 patients a year to keep accreditation. There's pressure to grow the program, but I remember one person saying, but I don't want to put this in anybody unless they're fully informed. And that's different than a lot of things in medicine where the docs are more than happy to convince patients to do things, whether they're informed or not. But I think they see these benefits and they see these complications and they've experienced them. And they talk about that, and they don't want to do that in somebody unless they really know what they're getting into. And so it helped us sort of understand why this context might be different than some others.
And I think along with that, there was this definitely huge theme of they talked about when they first started implanting, they were like, let's give it to everyone. And then they came back and had patients have really bad experiences. And they almost felt guilty about that. So they really wanted to take a step back and be very cautious and make sure that the patients were really informed. And so like one participant said, people call me Mr. Doom and Gloom. because, they really want to make sure that the pros and cons are expressed to the patient. So I think that also helps explain that, again, thinking about the step wedge and the time component. These sites were, I don't know, that again helps to support some of that, what we're finding in the quantitative.
Yeah, no, I think because they approved for destination therapy in 2009. We start the trial 2014. Their use is starting to go up. And now throughout the trial, they're starting to see more patients have complications. And that's where this sort of growing, not ambivalence, but this growing understanding of the magnitude of the trade-offs. And we felt that in the interviews. It's why they use the decision aid, but it's also why I have some concerns about the effectiveness outcomes and knowing what we really saw there with the step wedge design. Because there is a secular trend that we couldn't completely control for. I think you had a question here.
One of the things that about this kind of came to mind is what do they get as a consent? And how do they register what's in the consent? Should this eventually come up? Because a lot of times with procedures, you have to get this very objective list of things.
Yeah,
You trust this able to do the
that's right.
a living document that gives you kind of face on personal dialogue. And I don't know if this is
No, I think that's right. I mean, I think good shared decision making is really gold standard informed consent. I think informed consent is really the legal construct of shared decision making, but they're very, very similar constructs. But you're right, informed consent is often check this and sign it. And the ISHLT, the International Society for Heart and Lung Transplant, actually developed a consent document for LVADs, and it's 8 pages, 10-point font. Larry Allen found 8 typos in it, and they were really trying to be more comprehensive than your typical consent, but the design was just terrible. But a lot of what they said in there is the same things we said in our video, in a much more patient-friendly, patient understanding. So I think I would love for this to be part of consent. And in that next grant, one of the ways we're trying to influence laggards is to do some policy work to actually make this part of the consent process. So, right, I think it's a great comment.
I think one of the things that's also unique about the situation is that there's a whole process. So there is, so a patient has to be evaluated, and it's a multidisciplinary evaluation process. And then there's also a committee meeting that the medical team gets together and decides whether or not this patient is eligible. And then somewhere in there was formal education. And so that's one of the things that, the qualitative is figuring out what process they did each of those steps. And each site was a slightly different in terms of some did all their education up front and then evaluated them and then the committee meeting, but some did a little bit of education so the patient knows, but they don't want the patient to get their hopes up. And so I think that, again, speaks to this implementation challenge of, okay, at what point is the right point to introduce this decision aid? And it might be different at different sites depending on their processes.
Yeah, and just to you 1 second, but just to that, like one of the things we measured is how often was the caregiver present when they watched the video. In one site, it was like, I forget the number, 50%, whereas another site, it was 100%. Then through the interviews, you find out, well, we mandate the caregiver to be there. And you hear at these other sites, yeah, we just kind of do it at the outpatient, we do it whenever we can. And then you hear that qualitatively, and then you see quantitatively from the implementation how those two things sort of come together. I think she had a question, then I'll come to you, Patrick.
By having increased rates of LVAD the hospital may lose money, but potentially like Medicare would save money by not paying the cost of that and the complications.
Right, exactly.
Just
Yes.
a selling point.
Yes. Yeah, no, and that's actually, as we roll out in this next phase, that's the specific piece we're going to study is how concerned are you about reductions in utilization? Because we saw a 26% absolute risk reduction in our prior trial, and we know sites are concerned about that. And we know even here, they want to do the right thing, but then they're traveling to Cheyenne and Albuquerque and Grand Junction to try and get more referrals. So there's a system pressure to grow. But then at the individual level, that pressure, that financial pressure, they really didn't seem to play as much. They really wanted to make sure they were informed. But, so it's kind of interesting. I actually get frustrated when people say, oh, doctors are just functions of the incentives, because I don't think that's true. I think doctors, for the most part, want to do what's right. And that systems create these structures where incentives kind of play out.
I was wondering if you could discuss a little more that the decision regret did not decrease, because it seems like one of the main payoffs of a more informed, more values consistent decision should be less regret if those decisions are not working out better for them.
Yeah, I worry. So we have a lot of missing data at 6 months where we really look at regret, because there's a lot of patients that die. I think it's the sample size, but I also think it's missing not at random, and the people missing are the ones that may or may not have done well. And so, we were surprised to see less regret, or to not see changes in regret between the control and intervention. But I do think we have a sample size issue in 6 months where regret is probably the most valuable, and B, missing not at random issue. So this is a challenge with populations this sick. These are people dying in the ICU. You get a lot of missing data. Bethany.
So how did your sort of converged quantitative and qualitative data, your conclusions so far, inform this next grant that you submitted?
So that's a good comment. I think one of the things that Megan really highlighted in the analysis is the lack of communication. We really didn't do any supporting of the communication. And if you look at the diffusion of innovations theory, some of the things that really convince people to adopt are a good social system and the social structure and some sort of communication aspects. And so we built that in a lot more, with a lot more check-ins, not just with we had monthly calls with the site PIs, and we supported them, but we needed to do something else for the sites. And I don't know if we needed to do a lot, but we needed to do a little bit to remind them this is going on. Hey, when you bring new staff in, make sure they know about this. We don't want to do too much of that because we really want this to run on its own, and you can't monitor things like that, but we want to do a little bit of that. So I think that's probably the biggest finding that's influenced this one. I think the other ones is the fact that people were so hungry for the intervention, which is so different than any other shared decision-making. We decided to go big and go to all programs and do it virtually. Had we found from that prior trial that people were really skeptical, then maybe we would have picked 20 programs and done more hands-on. But because I think we universally hear that people want to do the right thing with informing these patients, I think we have a chance of going big, and we tried to play that argument in the grant. So those are a couple ways that prior finding influenced our thinking here. I'm sure there were more that I just didn't articulate very well. It's hard. This is one of the things about convergent methods, right? I can't imagine doing both qualitative and quantitative in the same data set and not having some convergence in your brain. It's almost like you naturally are starting to try to understand, well, is this because of this? Is this because of this? And so when that process of convergence happens, I can't imagine, I can't even think of a study where you wouldn't have some convergence. I think it's about being articulate about the convergence. Julie?
I just thought it'd be helpful to describe how you all practice converge. So what does that look like on a team? You have a quant team, your qual team is maybe something. How do you converge?
Well, we met quite a bit during the analysis.
You had a retreat.
And we had a retreat, and we did a 1.5-day retreat where we talked through the codes a lot. That was actually really formative. It was in July or August. We've kind of been on hold for a couple months because we're turning in 2 grants this month. So the implementation paper is on my plate to write. Megan keeps telling me, hey, Dan, when are you going to write that paper? And it's mostly written. But it's about bringing some of the qual stuff that we need to continue to analyze a little further to make sure we understand. But the process has been and will be continually getting together. I don't know how else you do it other than talking. I'd be curious if people have other approaches.
Yeah, so we had, that 1.5-day retreat. So we had, we broke up in the day with quantitative and qualitative, so that everyone heard, so everyone was there, so we could hear. But also part of that retreat was even just paper planning, and thinking, because there is so much data, and thinking about, okay, what's going to be quantitative, what's going to be mixed methods, and what's going to be qualitative. And I think that also is very, again, a kind of practical step of kind of planning it out to say, okay, this story for this paper that's going to be quantitative, can we tell that story without the qualitative, or do we need to tell the story with the qualitative? Okay, maybe that needs to be a mixed methods paper, or okay, this is purely qualitative. Do we need any quantitative? Well, no, we think this is just a qualitative story. So I think that also helps kind of direct thinking about, outlining. I mean, there's like 15, 20 papers that like kind of potential papers that kind of outlining and what data is going to go where and who's going to lead it, I think helped.
Yeah, we have a sheet outline prioritizing, because that's exactly right. Some papers are purely quant, some paper are going to be mixed, and then some will be purely qual.
Something maybe just to toy with is joint displays, or try to think about graphically how these data lay out, side by side. That might help stimulate the team's thinking, just in practice, thinking about thinking through your findings and how they
Yeah, no, that's interesting. It's just one of the sites, 95% of patients got an LVAD, and they did that pre and post intervention. And the interviews at those sites are really, that site are really different. One person at that site had us turn the recorder off to tell us how crazy their decision making was at their site and how much pressure patients are put under to get. She told us we could use it. She just didn't want to be recorded. So we could use our notes. So we don't have we took pretty detailed notes and wrote a summary, and she said that was okay.
For the qualitative, we did look at sort of our analysis kind of by provider type. So looking, for example, at all the social workers at each site. We also did analyses based off of each site, so that we could kind of look at trends across the different sites. And I would say the quantitative really helped inform for some of those, that site, and then our site that just didn't totally crash and burn, but
didn't do well.
Got into a fender.
Right. Yeah.
When thinking about this, the concurrent design,
Yeah.
what that would look like, the questions were the same essentially that you're asking, so that you would then blend them or mix them, or was it more thinking about how they would inform one another?
Because how we thought about that was before Megan was here when we designed this. But we did think about how they would inform one another. I mean, when we designed the checklist, we were thinking about the re-aim framework and what were the key core elements of the implementation. We wanted to check in a checklist, did they do those each time? And then when we designed the qualitative guide at the implementation, we asked about those things specifically as well. But and then we didn't actually do identical questions though. But we did kind of plan that this was something we were going to do ahead of time, is try to understand implementation both qualitatively and quantitatively.
Do we have anyone online who has a question? We have a bunch of people who are participating remotely. Does anyone have a question?
How would we know?
They would talk.
Oh, you can hear? Okay.
Okay. If you do come up with a question, you can either talk or type it into the, is there a chat in Zoom? Yes.
Yep. And I'm happy to hang out if people have
something that would show up.
Right.
Oh, right.
Any last questions in the room?
In your stepwise design, do you hear from any of the sites that they were burned out on there for a long period?
We didn't. We didn't at all. You mean burned out because they're been in it so long and haven't gotten to implement yet, or?
Well, or vice versa. They were a site that started the intervention at that 4-month period and continued throughout versus someone who started the intervention.
Oh, Yeah, no, and I think this is what's another unique thing about this context. In addition to people being interested in the shared decision making, you know, when you do shared decision making, decision aids in primary care, you have to figure out who's going to deliver it, who has the time. In this setting, you got this whole team of people meeting with people in the ICU, and they're already handing out materials. Ours just became another piece, so it didn't really feel like extra work. And that's partly why it was, we were kind of spoiled from an implementation perspective in this context, for those two reasons, I would say. 4 out of 10 for sure, or 4 out of 6 for sure. 1 is trying, and then 1's sort of waiting and hemming and hawing. They're concerned about that reduction in use.
My question, as you're doing this, did you make changes along the way in terms of materials?
The materials stayed pretty static. We did at the end of the trial learn that all the sites were not just using them for the destination therapy patients, but also for the bridge patients. And the data is pretty similar. So for this next trial, we've modified our decision aid based on that and a few other things we've heard from the sites, things they would, just small tweaks. But yeah, we went through 20 versions of the paper tool and 4 versions of the video tool before the trial with sort of a lot of user input. So luckily we didn't have to do too much of that. All right, I think we're at noon here, so maybe we should, or 1 o'clock, we should call it. Thank you all. Thanks, Megan.
Have one, I can.
You didn't sign in too, please.
I remember if I introduced myself in person, so I want to make sure. I guess I was one of them. Yeah. I probably know I've been helping Dr. Code with the Dev project. Yeah. But I just had a thought in the middle of your presentation about your presentation. So in your, I don't think you had a visual on screen, but your video that you were showing patients. Yeah. Specifically when you were talking about patient narratives, I was almost, I had the idea that you could do sort of a picture, maybe a distribution where that person's narrative is. That's kind of cool. Yeah. So if they're really extreme on one side or the other, that's kind of cool. I even kind of drew a keyword. Yeah. I could see you have like a few faces and hear somebody very pro, and then as each person speaks, maybe the patient could kind of get an idea of how average that person's doing. Yeah. So maybe, like you were saying, a guy who was doing pull-ups way over there on the side, so they can kind of get a visual picture of how realistic that is. Yeah, because that is a challenge of awareness. I mean, and getting downstairs is really hard. Yeah, so I just wanted to throw that your way because I thought it was pretty helpful. Yeah. Otherwise, I thought it was a fantastic presentation. Oh, thank you. I'm impressed with how well you guys did, how kind of muddy everything got to this. Yeah, yeah. No, thanks. Yeah, thanks for presenting. Yeah. See you later.
Yeah, I wanted
Just resting with yes. Oh, cool. I'll soup it up. Thank you. Yeah, we did adjust for clustering with insights. And we adjusted for how some sites later in the trial started using the decision aid earlier. So we adjusted for that difference.
I thought it was really good. I put a note in our stuff to like make sure that we think about questions beforehand, maybe. Because I feel like today people asked a lot of questions about how the mixed methods came into play, whereas I was typing in the notes from 2 ago. I found the one that I was missing. That's what they were saying. Like, could you talk about not just both sides, but how they came together? So yeah, that was great.
No, that's good. If I had more time last night, I would have put some of the quotes in, but I just
well, I think both of you talking was, you know, I didn't all need to be there. You came up with some good ones. And, yeah. It's fun. Yeah, it's cool.
Talk about the study.
I have a question. When you are scouting, yeah,